Chapter 28, the Reproductive System, Screencast 2. This screencast will be focusing on the following structures of the female reproductive system: the uterine tube, the uterus, the vagina, and also focusing on the uterine cycle. And the last slides will be integrating the uterine cycle also with the ovarian cycle and all female reproductive hormones. Now, uterine tubes, formerly known as the fallopian tubes, and either name is acceptable. They extend laterally from both sides of the uterus towards the ovaries, and their role is to transport an ovulated oocyte to the uterus. The infundibulum, that is actually a funnel-shaped lateral margin of the uterine tube. It has numerous finger-like folds known as the fimbriae. And the fimbriae actually will enclose the ovary only at the time of ovulation. So kind of imagine that you basically have a funnel and the fimbriae completely encircling or enclosing the ovary, making sure that the egg can only go one place once ovulated. The ampulla, that is the expanded region of the tube and is medial to the infundibulum, and this is typically where fertilization of the oocyte actually takes place. The isthmus, that is the region of tube extending medially from the ampulla, and the uterine part of tube extends medially from the isthmus and penetrates the wall of the uterus. Now, once again, we do want to put an emphasis on the layers, and we have the mucosa, the muscularis, and the serosa. The mucosa is made up of simple ciliated columnar epithelium. There is an underlying layer of areolar connective tissue. And once again, there's linear folds that are actually reducing the size of the lumen tube. The cilia are on the apical surface, and they beat in the direction of the uterus. So they actually only beat in a single direction. And what this beating motion does, it draws the oocyte into the tube towards the uterus. The muscularis, this is an inner circular layer and outer longitudinal layer. And the contractions of the muscularis propels the pre-embryo through the uterine tube towards the uterus if fertilized. As usual, the serosa is just an external serous membrane that is covering the uterine tube. Now, in this clinical situation, they're talking about tubal pregnancy. In particular, this is an ectopic pregnancy, and the fertilized oocyte implants outside of the endometrium. In a tubal pregnancy, this is one type of ectopic pregnancy. The fertilized egg actually implants itself within the uterine tube and not the uterus. The tube is unable to expand as the embryo grows. In this situation, the embryo is typically only viable until week 8. The uterine wall will rupture if the embryo is not removed, and we are now looking at significant hemorrhage, and loss of life is possible in this situation. Now, the function of the uterus, and this is a pear-shaped muscular organ, and remember, this is where the pre-embryo will be implanted. And the role of the uterus is to support, protect, and nourish the developing embryo. They will form a vascular connection that eventually develops into the placenta. The uterus will eject the fetus at birth, so there's childbirth, and also the lining will be shed if the oocyte is not fertilized. Now, if we look at the anatomical areas of the uterus, they are as follows. The fundus, this is a broad superior region between the attachments of the uterine tubes. The body, this is the middle region. It's the major part of the uterus and has a thick muscular wall. The isthmus, this is a narrow constricted inferior region superior to the cervix. So the isthmus is not the cervix. The cervix is the narrow, most inferior most part of the uterus, and it actually projects into the vagina. Now, if we look at the cervical canal, that is the narrow channel within the cervix, There are two areas that are associated with the cervix, and they are the internal os, that is the superior opening of the cervical canal, and also the external os, and that is the inferior opening of the cervix into the vagina. Now, there is something called a mucus plug at the external os, and this is actually formed by mucin-secreting glands, and the role of these glands are to prevent pathogens from invading the uterus from the vagina. This mucus plug will actually thin around ovulation so that it is easier for sperm to penetrate. Now, there are a number of supporting structures of the uterus, and most of them are ligamentous in nature. We have the round ligament. This extends from the lateral uterus and transverse inguinal canal, and it attaches to the labia majora. Transverse cervical ligaments, these run from sides of the cervix and superior vagina laterally to the pelvic walls. The uterosacral ligaments, these connect the inferior uterus posteriorly to the sacrum. And when these weak ligaments actually protrude, or you have a weakness in the pelvic floor, the uterus actually starts to protrude through the vagina, and this is called a uterine prolapse. Now, we want to address the tunics of the uterus. First is the perimetrium. This is the outer tunic serosa. It's continuous with the broad ligament. I generally don't address this layer to a great extent. Now, what will be important is the myometrium. This is the thick middle tunic of the uterine wall, and it is 3 intertwining layers of smooth muscle. So this is the muscle that's actually responsible for uterine contractions. The endometrium, that is the innermost mucosal tunic of the uterus, but what's important here is to keep in mind it is subdivided into 2 areas. There is a permanent layer, and this is the layer that undergoes few changes during each uterine cycle. There is a more superficial functional layer, and this is the layer that actually begins at puberty. It grows from a basal layer under influence of estrogen and progesterone, and if there is no fertilization, this is the layer that's actually shed at menses. The permanent layer of the endometrium is not shed. That's an important thing to keep in mind. The vagina, this is a thick-walled fibromuscular tube. It is the most inferior region of the female reproductive tract. It connects the uterus with outside of the body. It functions as the birth canal. It is responsible for receiving the penis during intercourse, and it is also a passageway for menstruation. Now, the mucosa of the vagina, this is a non-keratinized stratified squamous epithelium. Remember, we're talking here about mechanical stress that is associated with intercourse. It has a very vascularized lamina propria. The other thing to keep in mind here is the mucosa is producing acidic secretions, and that is to prevent infection. The inferior region, with numerous transverse folds and projects into the lumen near the vaginal opening or vaginal orifice, forms a vascularized membranous barrier, the hymen. The muscularis has outer and inner layers of smooth muscle. And once again, the adventitia, this contains inner elastic fibers and is the outer layer of areolar connective tissue. Now, here we're looking at a clinical situation known as endometriosis. This is a condition when the endometrium is displaced. Tissue becomes implanted on external surface of organs within the abdominal pelvic cavity. Now, the endometrium may grow under influence of hormones. So in this situation, it cannot be expelled normally. It may cause pain and scarring. It often is also linked to fertility issues. The treatment for endometriosis is typically hormones to retard the growth of endometrial tissue or surgery. So it is not uncommon that some women may actually be prescribed hormonal contraception for something other than contraception, and endometriosis is one of those situations. Another situation that needs to be addressed is cervical cancer. This is a very common malignancy that's associated with the female reproductive system. And when we look at the most important risk factor for this, it is HPV, or the human papilloma virus. Currently, there is a vaccine known as Gardasil, and it is available for 4 of the most common types of HPV. The screen is a pap smear, and what this does, this detects cervical cancer in the early stage. Basically, epithelial cells are scraped from the cervix, and these cells are examined for abnormal development. If cancerous cells are present, then portion of the cervix is removed. If it is an invasive cancer, then there will be the entire uterus removed, and that is a hysterectomy. Now, next we'll be addressing the uterine cycle, and this is also known as the menstrual cycle. During the uterine cycle, there are cyclical changes in the endometrial lining, and remember, these changes are going to be influenced by estrogen and progesterone. There are 3 distinct phases of development, and the order is menstrual phase, proliferative phase, secretory phase. Sometimes it's easy to get the last 2 phases flip-flopped, so the easiest thing to do is just follow the alphabet, MPS. So menstrual phase, proliferative phase, secretory phase, and once again, we'll be using a standardized 28-day uterine cycle, but remember, this varies and is very individual, and there are cycles as short as 21 days and as long as 35 days. Now, during the menstrual phase, this is days 1 through 5 of the cycle. This is the shedding off of the functional layer. This lasts through the entire period of menstrual bleeding. The proliferative phase, this would occur during days 6 through 14. There is the development of new functional layer of the endometrium, and this does overlap time of follicle growth and ovary estrogen secretion. The secretory phase, this is days 15 to 28 of cycle. Now we have increased progesterone levels from the corpus luteum. This is what actually results in increased vascularization and the formation of uterine glands. If fertilization does not occur, there will be degeneration of the corpus luteum, a dramatic drop of progesterone, and without progesterone, the functional layer will be shed and the cycle starts all over again. Now, this is an important diagram here because it is demonstrating the interaction between everything having to do with the female reproductive system from a hormonal standpoint. The first top image, we're looking at gonadotropin levels, and those are follicle-stimulating hormone and luteinizing hormone. We then have follicular development. Then we actually have the ovarian cycle. We also look at the relationship between the ovarian hormones, estrogen and progesterone, and then we tie that all in with the uterine cycle. So let's kind of look at what's going on here. Basically, we split this up into a standard 28-day cycle, and we can see as far as the menstrual cycle goes, we have days 1 through 5, which are the menstrual phase. And remember, this is when the functional layer of the endometrium is being shed. And what we can see here, there are relatively low levels of both follicle-stimulating hormone and luteinizing hormone. Now, during the time when we have follicle-stimulating hormone and luteinizing hormone, notice we have, at this time, a higher level of FSH than LH. And this is where we start to see the primary follicle going into the secondary follicle. But we can also see here, as far as the ovarian cycle, the antral follicle grows, the mature follicle, and at day 14, we have ovulation. We'll come back to this, okay? We can also clearly see during the follicular phase that the primary hormone is estrogen. As we get closer to ovulation, we can see that there is a dip, then a spike in follicle-stimulating hormone, but look at the significant increase in the amount of luteinizing hormone. And remember, this is what's actually stimulating ovulation. So now, at ovulation, we can actually see a beginning in the flip-flop of the hormones. So now, when it comes to the ovarian phase, we are looking at the corpus luteum. And remember, the corpus luteum is primarily secreting progesterone and some estrogen. Look here at the significant difference in the increase in levels of progesterone during the luteal phase. What also is really interesting, you can basically almost put over the curve of progesterone and it mirrors almost exactly the secretory phase. So this really demonstrates the relationship that the uterus has with progesterone and how important it is with respect to the uterine cycle. This last diagram here is a really good diagram which basically summarizes the entire cycle. I'm not going to go through the whole thing, but I definitely recommend taking a look at this because it is a nice walk through the entire 28-day cycle. Basically, the first panel is looking at days 1 through 5, the second panel 6 through 12, the third panel 13 to 14, and then the final panel is actually looking through days 15 to 28, and it really is linking everything that's happening together in this particular diagram.